Welcome. HIV, human immunodeficient virus. Human immunodeficient virus, acquired immunodeficiency syndrome, first described in 1981. HIV-1 isolated in 1984 and HIV-2 in 1986. Belonged to the lentivirus subfamily of the Retroviridae. Enveloped RNA virus, 120 nanometer in diameter. HIV-2 shared 40% nucleotide homology with HIV-1. Genome consists of 9,200 nucleotides. HIV-1, gap core protein B15, B17, B24, ball protein 16, protease, B31 integrase and endonuclease, envelope GB160, GB120, outer membrane part, GB141, transmembrane part. Other regulatory genes, i.e. TAT, WAVE, PIR, NAF, VDR, and VP HIV particle, and is under electron microscope, and this is detailed structures. This is the transmembrane glycoprotein GB21 with the envelope glycoprotein GB120, and here the viral genome RNA, and here the reverse transcriptase enzyme, reverse transcriptase, and here the nucleoid core protein B24, and here matrix core protein B17, here the envelope, HIV genome, LTR, egg, boy, leaf, and this VBR, and this envelope, and LTR. Replication. The first step of infection is the binding of GB120 to the CD4 receptor of the cell, which is followed by penetration and uncoating. The RNA genome is then reverse transcribed into a DNA through virus, which is integrated into the cell genome. This is followed by the synthesis and maturation of the virus probe. Here, the virus adsorbed on the cell membrane of CD4, penetration and uncoating, and here reverse transcribed, assembled, integrated on the host DNA. After that transcribed and translation occurred to viral protein is formed. There thin assembly occurred, nucleocapsid is formed, and here the body and the release of the virus. Clinical features: seroconversion illness seen in 10% of the individual a few weeks after exposure, and coincide with seroconversion present with an infectious mononucleosis like illness. Seroconversion illness seen in 10% of individual a few weeks after exposure and coincides with seroconversion present with an infectious mononucleosis like illness. Incubation period. This is the period when the patient is completely asymptomatic and may vary from few months to more than 10 years. The median incubation period is 8 to 10 years. AIDS related complex or persistent generalized lymphoadenopathy, fall down, opportunistic infection, protozoal, pneumocystis carinii, now thought to be a fungal, toxoplasmosis, cryptosporidiosis, fungal candidiasis, herpetococcidiosis, histoplasmosis, coccidiomycosis, bacteria, mycobacterium avian complex, atypical mycobacterial disease, salmonella septicemia, multiple or recurrent pathogen bacterial infection, viral, cytomegalovirus, HSV, varicella zoster, GCV, opportunistic tumors. The most frequent opportunistic tumor, Kaposi sarcoma, is observed in 20% of the patients with AIDS. TS is observed mostly in homosexual and is relatively incidence is declining. It's now associated with human herpes virus 8, HHV8. Malignant lymphoma are also frequently seen in AIDS patients, sarcoma. Other manifestation, it's now recognized that HIV-infected patients may develop a number of manifestations that are not explained by opportunistic infection of tumor. The most frequent neurological disorder is AIDS encephalopathy, which is seen in 2/3 of the cases. Other manifestations include characteristic skin eruptions and persistent diarrhea. Epidemiology, sexual transmission, male homosexuals and constitute the largest risk group in North America and Western Europe. In developing countries, homosexual spread constitute the most important means of transmissions. Blood and blood product, IV drugs abuser, IV drug abuser represent the second largest AIDS patient group in US and Europe. Hemophilic were one of the first risk group to be identified. They were infected through contaminated factor 8. The vertical transmission, the transmission rate from mother to the newborn varies from around 15% in Western Europe to up to 50% in Africa. Vertical transmission may occur transplacentally, root prenatally during the birth process, or postnatally through culture. HIV is present at a high level in blood, as detected by HIV antigen, HIV RNA assay. It's then settled down to certain low-level set point during the incubation period. During the incubation period, there is a massive turnover of CD4 cells, whereby CD4 cells killed by HIV are replaced efficiently. Eventually, the immune system succumbs and AIDS develop when killed CD4 cells can no longer be replaced, witnessed by high HIV RNA, HIV antigen, and low CD4 counts. HIV half-lives, activated cells that become infected with HIV-produced virus immediately and die within 1 to 2 days. Production of the virus by short-lived activated cells account for the vast majority of the virus present in plasma. The time required to complete a single HIV life cycle is approximately 1.5 days. Resting cells that become infected produce virus only after immune stimulation. These cells have a half-life of at least 5 to 6 months. Some cells are infected with defective virus that can't complete the virus life cycle. Such cells are very long-lived and have an estimated half-life of approximately 3 to 6 months. Such long-lived cells population present a major challenge for antiretroviral therapy. HIV half-lives, plasma virus, half-life per minute, the productivity infected lymphocytes, and the long-lived cells, and effective laboratory diagnosis. Serology is the usual methods of diagnosis of HIV infection. Serological tests can be divided into screening and confirmatory assay. Screening assay should be as sensitive, whereas confirmatory assay should be as specific as possible. Screening assay, EIA, are the most frequently used screening assay. Sensitivity and specificity of the present available commercial system now approach 100%, but both positive and negative reaction occur. Some assays have problem in detecting HIV-1, a subtype of confirmatory assay. Western blot is regarded as the gold standard for serological diagnosis. However, sensitivity is lower than screening EIA. Line immunoassay incorporates various HIV antigen on nitrocellulose strip. The interpretation of the result is similar to Western blot. It is more sensitive specific. ELISA for HIV antibodies. Micrograde ELISA for HIV antibodies electrolytes indicate reactivity. Western blot for HIV antibodies. There are different criteria for the interpretation of HIV Western blot resulting of CDC, WHO. The most important antibody are those against the envelope glycoprotein 120, GB160, and GB141. GB24 antibody is well present but may be absent in later stage of HIV infection. Other diagnostic assay, it's normally take 4 to 6 weeks before HIV antibody appears following exposure. A diagnosis of HIV infection made earlier by the detection of HIV antigen through DNA or RNA. However, there are very few circumstances when this is justify diagnosis of HIV infection in babies born to HIV-infected mothers. Prognostic test. Once a diagnosis of HIV infection has been made, it's important to monitor the patient at regular for signs of disease progression and response to antiviral chemotherapy. HIV antigen test. They were widely used as prognostic assay. It had also apparent detection of HIV. B24 antigen was not as good as serial CD4 counts. The use of HIV B24 antigen assay for prognosis has now been superseded by HIV RNA assays. HIV viral load in serum may be measured by assay which detects HIV RNA reverse transcriptase proteins PCR, NASP, or branched DNA. HIV viral load has been established as having good prognostic value and in the monitoring response to antiviral chemotherapy. Here, months, year, the immune response, CD4 cell count, plasma virus RNA, virus in the blood, and here the symptoms. Treatment, AZT, Zidovudine, was the first antiviral agent shown to have beneficial effect against HIV infection. However, after prolonged use, AZT resistant strains rapidly appear, which limits the effect of AZT. Combination therapy has now been shown to be effective, especially for trials involving multiple agents, including protease inhibitors. The rationale for this approach is that combining drugs that are synergistic, non-cross-resistant, and no overlapping toxicity, it may be possible to reduce toxicity, improve efficacy, and prevent resistance from RNA. Antiretroviral agent, nucleoside analog reverse transcriptase inhibitor like AZT, non-nucleoside analog reverse transcriptase inhibitor, protease inhibitor, HAART, high active antiretroviral therapy. The regime normally comprises 2 nucleoside reverse transcriptase inhibitors and protease inhibitors. Prevention. The risk of contracting HIV increases with the number of sexual partners. A change in the lifestyle would obviously reduce the risk. The spread of HIV through blood transfusion and blood product had virtually been eliminated since the introduction of blood donor screening in many countries. AZT has been shown to be effective in preventing transmission of HIV from the mother to the fetus. The incidence of HIV infection in the baby was reduced by 2/3. The management of healthcare workers exposed to HIV through incubation accidents is controversial. Antiviral prophylaxis had been shown to be of some benefit, but it's uncertain what is the optimal regime. Vaccines are being developed at present, but progress is hampered by the high variability of HIV. Clinical trials for several vaccines are in progress.